diagnosed with bladder cancer mean?
Well, when a patient has been told that they have bladder cancer, they really at first are quite shocked by that and are concerned what this means to them in the long run. Usually bladder cancer is a superficial disease that means it can be treated by a local treatment, usually with a scope, not involving a major surgery, but rather a brief outpatient procedure that can oftentimes lead to the diagnosis, and a lot of times that may be the only treatment that's necessary as well.
How is bladder cancer treated?
Bladder cancer is usually treated at first with some type of outpatient procedure where a scope is put in the bladder and the tumor is essentially scraped out, much like a colon polyp is done with a colonoscopy by a colorectal surgeon or a gastroenterologist. And then following that procedure, the pathology is reviewed with the patient, and depending if there's no invasion at all, then that's all the treatment they need, and then they just need close follow-up. If there's evidence of invasion into like the first layer of the bladder wall, which is called the lamina propria, then they might need what's called an intravesical treatment, which is some form of medicine that's put in the bladder on a weekly basis, usually for about 6 weeks. If the bladder tumor is muscle invasive, which is a relative rarity, that's probably less than 30% of the time, at least on the first tumor someone has, that's a lot more serious of a condition and can require even removal of the bladder or some form of combination of radiation therapy or chemotherapy.
Can bladder cancer be cured, or will my bladder be removed?
The good news about most patients with bladder cancer is that most of them are either cured or very well controlled for the rest of their life. The risk of dying of bladder cancer, if you've been given that diagnosis, is a lot less than like if you were given a diagnosis of lung cancer or pancreatic cancer. Invasive bladder cancer, if it invades into the wall of the bladder, so-called muscle invasive disease, does carry a significant risk of death from it if not treated aggressively and appropriately. But the vast majority of people who have bladder cancer have a superficial type that can be recurrent. The risk of recurrence of bladder cancer in the first year is about 15%, and it's about 30% by the time you finish your second year of follow-up. But usually can be treated, and treated by repeat resection, and again, there are medicines that can be given that may decrease the risk of recurrence. And as far as does someone need to lose their bladder in the whole process, it does happen. We do have people that have to have what's called a radical cystectomy, but again, that's a lesser subgroup. Those are people that either have muscle invasive disease or have super bad recurrent cancer that need it treated that way.
What increases my risk for bladder cancer?
Risk factors for bladder cancer have been studied for many years. It's actually one of the most interesting cancers from that standpoint, because when we ingest things or are exposed to environmental toxins, your body tends to take them and excrete them, and then in the process your bladder stores them. And so probably the biggest risk factor of them all for bladder cancer is smoking. Basically it increases the risk for bladder cancer many fold and puts people at great risk for bladder cancer. Are there non-smokers who develop it? Yes. What other factors can put someone at risk for bladder cancer? One of them is previous radiation therapy. We certainly see men who've had prostate cancer and were treated with radiation therapy. It does increase the risk of bladder cancer in the long run. There are women who are treated for different kind of gynecologic malignancies by radiation therapy that are increased risk. Another one that we see not uncommonly is women that are treated with Cytoxan, which is a form of chemotherapy for breast cancer. There's something in that tends to increase the risk for bladder cancer as well. And then there are some kind of other risk factors. For instance, males are higher risk than females. Is that because more males smoke? I think there's still probably some increased risk for males beyond that. And then also the white or Caucasian race is at higher risk as well.
Testicular cancer is a cancer of the testes, which is highly curable. The testicular cancer is to be very difficult to treat about 30 years ago, 35 years ago. Now we have a cure rate of 95%, provided we take care of them and early diagnosis and treatment. There are no known risk factors except what we talked about earlier. Undescended testes, one of the causes of testicular tumors. There are no other known causes. It is very important every male should examine themselves at least once a week, and especially the people between age 15 to 35. It's very important. The testicular cancers are very common in that age group. Self-examination and going and consulting your doctor, they evaluating with various radiological examinations. Then, if they suspect a testicular tumor, it's very important to make sure what they have is not a cancerous growth on the testes. It is diagnosed by self-examination and the physicians deciding by radiological as well as physical examinations that they have a tumor, then removing the tumor and examining it under microscope. There are different kinds of testicular tumors. Some are highly curable, some need more treatment after the removal of the testes. That does not really increase the risk of testicular cancer, but they need to be examined, determined whether they have any underlying growth in the testes. Usually I don't advocate placement of prosthesis. If somebody wants a prosthesis, it can be placed. Depends whether somebody needs further treatment for testicular cancer. If they have radiation therapy or chemotherapy, they may have difficulty in fathering the children. There are different ways we can help them by preserving the semen, or some of these patients may not need any further treatment after removal of the testes. They will be able to have children. Depends upon the treatment. By just removing the testes, they may not need any sperm banking. If they need chemotherapy or radiation therapy, then we need to discuss that. The answer is no, unless they received chemotherapy or radiation therapy. Normally, that does not affect their sexuality.
Vulvodynia is a chronic burning and pain in the vagina without any identifiable cause or reason for this pain. Patients typically describe burning with intercourse, or they could describe this pain or burning generally around the vagina all the time.
The issue of testosterone treatment for men and women is huge. We know that testosterone is one of the 4 main categories that we look at when we try to identify what the problem is or what the etiology of the concern is when people come to our clinic with complaints. Testosterone is a hormone that both genders need, that is really the foundation of sexual function. It gives us our interest, our libido, our sense of arousal, our sense of interest. In men, that is the hormone that allows us to have morning erections. These are hormones that really are required to get the ball rolling, if you will. And a lot of the medications we hear about in the media, Viagra, Levitra, Cialis, those categories of medications or PDE5 inhibitors require an appropriate level of hormones for those pills to work. So it's really paramount in our evaluation and treatment to replenish those patients who have low testosterone. In women, it's really the same issue. We will test levels, and if they are at a level that we are concerned about in conjunction with the level of symptoms that they have, then we will choose to treat.
The Department of Sexual Health is a unique facility dedicated to evaluating and treating both men and women for sexual dysfunction. We are proud to offer such a facility and reach out to our community in an effort to raise awareness about the potential risks that cause sexual dysfunction. We believe that this private issue is becoming more open to discussion with the men and women of today, and we are here to help rekindle relationships as well as teach wellness, healthy lifestyles, and bring back a quality of life we all deserve. At the Department of Sexual Health, we are here for you when you're ready for us. What does it mean if I have a kidney mass?
So a modern phenomenon of medicine now is that we have patients that are told they have a mass in their kidney, and yet they had the CT scan done for another reason. I actually just saw an article on my desk today that was talking about the increased survival of patients with kidney cancer that are diagnosed in such a fashion with what we call an asymptomatic or incidental finding. If you look at all kidney masses, solid kidney masses that are found, let's say on CAT scan, about 80% of them are malignant or considered kidney cancer. There still is a decent chance, 20% or less, that it's some form of benign lesion. There are some unusual kind of fatty type of tumors that can have an appearance like this. And then there's some other different subtypes of tumors that aren't so aggressive that are still considered a solid mass.
What are the usual treatments for kidney cancer?
So if one has a mass that's of a certain size and appearance on a CT scan or initially ultrasound and then with some follow-up study, there's a high percentage that it could be a kidney cancer, approximately 80%. Sometimes those patients are biopsied. A lot of times they're not, for a couple reasons. One is if the mass is big enough and suspicious enough, the risk of it being kidney cancer is so high that they probably don't need to undergo the biopsy. Once someone has a scan that shows that suspicious lesion, the most common treatment would probably be a removal of the entire kidney if the lesion's over a certain size, which is usually about 4 centimeters. If it's under 4 centimeters, a lot of times the kidney can be removed. Sorry, the portion of the kidney that has the mass in it can be removed, what's called a partial nephrectomy. And then there's been some kind of exciting new treatments in the last few years where instead of removing a portion or a part of the kidney, the mass is actually treated where it's located, either with something called radiofrequency ablation, or the other option is cryotherapy. And what those are is cryotherapy is to actually freeze the mass, and then radiofrequency ablation is actually to treat it with what's called radiofrequency, which essentially cooks the mass.
Can kidney cancer be cured, or will my kidney be removed?
Will it be cured is, I think, a very reasonable concern or aspect for patients that have kidney cancer. Your patient's curability depends a lot on the size and the stage of the initial tumor. If we're presuming that the patient has no obvious metastases away from the kidney on CAT scan or other imaging study, their chances of being cured are very high, probably overall about 90% with a 10-year survival rate, meaning that at 10 years, 90% of the people are cured. That's if it's confined within the kidney and that type of thing. Now it gets a little worse the bigger the tumor is and these other different parameters, but just as a rule of thumb, that's a good number. At those lesser procedures I was talking about earlier, so it's a smaller mass, let's say like a 2 or 3 centimeter mass treated, their cure rate, if treated by cryotherapy or radiofrequency ablation, is still very good. They have actually about an 80% cure rate at 10 years. And so for a lot of patients, if they have a lot of other illnesses and that type of thing, if you weigh back and forth the risk of doing a surgery or moving part of the kidney and putting all that on the table versus having a radiofrequency ablation done by an interventional radiologist, you're only exchanging a 10% cure rate at 10 years for that, so it may be worthwhile for them. But for some people, that 10% is worth it for them, and it just depends on the patient themselves and the location of the lesion and a lot of other factors. But it's the exciting thing is there's a lot more choices and options now in treatment of it.
The female pelvic floor is a combination of all of her pelvic organs, which include her uterus, tubes, ovaries, and cervix, her bladder, her vagina, her rectum, as well as her pelvic floor muscles, which are called the levator ani muscles.
There are a number of issues. One is a psychological issue. I've had a major operation that has removed my ability or eliminated my ability to bear children. Big issue, big psychological issue. When you talk about a total abdominal hysterectomy with removal of the ovaries as well, the ovaries in women is the organ that offers approximately 50% of the hormones that women need to feel sexual. And so having a hysterectomy and oophorectomy where the ovaries are removed or removing a major source of hormones. There are nerves in and around the cervix that are potentially affected during an operation that can decrease sensation as well. The real point of this is that there are remedies for people who have had a hysterectomy and are noticing a decline in sexual response. And those remedies can be easily identified with certain testing, certain questionnaires, certain laboratory evaluations. The other obvious concern is that some hysterectomies are done for major cancer issues. And then we talk about the whole psychological aspect of being a cancer survivor and their ability, a woman's ability to be sexual as well. So they're both physical, emotional, and hormonal concerns that we have to look at when we address these issues.
The Department of Sexual Health is a unique facility dedicated to evaluating and treating both men and women for sexual dysfunction. We are proud to offer such a facility and reach out to our community in an effort to raise awareness about the potential risks that cause sexual dysfunction. We believe that this private issue is becoming more open to discussion with the men and women of today, and we are here to help rekindle relationships as well as teach wellness, healthy lifestyles, and bring back a quality of life we all deserve. At the Department of Sexual Health, we are here for you when you're ready for us.
Well, the definition of pelvic organ prolapse is a herniation or dropping of the pelvic organs at or beyond the vaginal wall. Some of the symptoms that a patient will typically complain of is feeling a vaginal bulge or protrusion. They feel like their insides are falling out. They might feel like they're sitting on something. To diagnose this problem, typically, well, actually, it does require a vaginal examination, most commonly with a speculum and doing the pelvic organ prolapse quantification examination.
We know that testosterone in well-supervised, medically appropriate dosing is really a safe hormone. In fact, the lack of testosterone, low testosterone levels, is more of a concern. It's been linked to cardiac disease, it's been linked to depression, it's been linked to increased pain problems, and it's been linked to poor bone strength and bone fractures. So I'm more concerned really about the lack of testosterone. The things that we see about in the media about people who are abusing testosterone, sports figures, wrestlers, weightlifters, that's a whole different category, and we're talking about magnitudes of doses that are much greater than we will offer in a medically appropriate spectrum. Men and women will commonly see a little bit of weight gain. That weight gain is muscle mass. We actually see an improvement in fat levels in men and women when appropriate amounts of testosterone is being used. So a weight gain will be identified, but it should lessen the amount of body fat percentage. We look at increased oily skin. Some men and women will have increased acne. Those are all dose-dependent responses. We can decrease those doses as necessary. In men and in women, we will sometimes see a male pattern baldness if the testosterone becomes too high. We can decrease those doses again if that becomes an issue. In men who have a characteristic thinning of the hair on top and receding of the hairline along the forehead, that's usually seen as a testosterone level that might be inappropriately high. We'll see engorgement of the penis, and we'll see engorgement of the clitoris as well. That's a positive response. If the engorgement becomes too significant or becomes too persistent, that is an issue and that is a concern, and that's why we monitor these levels very, very aggressively. Laboratory values and physical exam needs to be offered frequently. I worry about something called polycythemia vera, which is a thickening of the blood, increasing hemoglobin. Testosterone, again, is a bodybuilding hormone. It increases protein mass. It can increase blood flow, not blood flow, but it can increase levels of the hematocrit and hemoglobin. If the blood becomes too thick, that's problematic and a dangerous situation. Again, that needs to be monitored. The biggest concern, and there's a lot of disinformation regarding prostate health, prostate cancer, and the use of testosterone. 10, 15, 20 years ago, prostate cancer patients were kept away from testosterone. It was felt that testosterone will actually feed prostate cancer growth. Over the last 5 to 10 years, we've actually taken another look at the relationship of testosterone and prostate cancer, and we understand right now, we're fairly comfortable with an understanding that appropriate amounts of testosterone being appropriately monitored can be safe in the prostate cancer patient. But that's something, very importantly, that's something that you and the patient with prostate cancer and the doctor have to have a very well-informed, strong interface and discussion regarding the potential risks and benefits in that scenario.
The Department of Sexual Health is a unique facility dedicated to evaluating and treating both men and women for sexual dysfunction. We are proud to offer such a facility and reach out to our community in an effort to raise awareness about the potential risks that cause sexual dysfunction. We believe that this private issue is becoming more open to discussion with the men and women of today, and we are here to help rekindle relationships as well as teach wellness, healthy lifestyles, and bring back a quality of life we all deserve. At the Department of Sexual Health, we are here for you when you're ready for us.
PSA stands for prostate-specific antigen. It's actually an enzyme that's made by the prostate to help make the semen a lot thinner so that it travels farther. So it is something that's supposed to be present in the male body. PSA should be checked on a yearly basis for gentlemen who have normal prostates. It's still considered a yearly exam for screening purposes. As of now, the PSA is a normal thing that's made by the body. So when patient asks if there is anything you can do to prevent the rise in a PSA, not necessarily. Occasionally, the PSA can rise due to different reasons. It doesn't necessarily have to mean prostate cancer. Other rises that can occur can be due to just an enlargement of the prostate. That occurs as men grow older. In addition, you can have inflammation of the prostate secondary to an infection or just due to inflammation. Part of what an inflammation can occur is when bike riders tend to be on their saddle for long periods of time, or motorcycle riders, is there potential that they can rise a PSA? Absolutely. Because of the fact that you're putting trauma onto the prostate, it will actually cause an inflammation. With that inflammation, the PSA will rise. So that the reason for an elevated PSA isn't necessarily prostate cancer. BPH stands for benign prostatic hypertrophy. It means an enlargement of the prostate, and that's what people always talk about. BPH, what is it, what is it? And it's just an enlargement of the prostate. It occurs as men grow older. The reason for that is because of the fact that throughout their lives, testosterone is around. Testosterone makes the prostate grow, and as it grows, it starts to enlarge, and it causes an obstruction of the urethra, which is the urinary tube. And so if it causes an obstruction, men start to have difficulty urinating. TUMT is a procedure done in the office to help alleviate the symptoms of BPH. TUMT stands for transurethral microwave therapy, and what it is actually a heating of the prostate whereby you can shrink the prostate. And so it's a therapy that can be done in the office. It only takes about an hour. It's something that's covered by most insurances, and as well, patients do quite well afterwards without the need for either medications or surgical intervention. When we talk about BPH, we need to consider a continuum of treatment options. That starts off with medical therapy. That's the first line of therapy. Other therapies can include microwave therapy, which is the TUMT. There's surgical interventions, especially transurethral section of the prostate, commonly known as a roto-rooter. There is surgery to take out the prostate, also known as a prostatectomy. It's a little bit bigger surgery. And then there are newer therapies that are also being used, such as radiofrequency ablation, needle ablation, and laser therapies. Some symptoms of BPH can include difficulty urinating, getting up in the middle of the night to urinate, slow flows with low volumes, urgency and occasionally frequency, with long-standing obstruction secondary to the enlarged prostate. Other symptoms can start to happen, such as pain in the suprapubic area, which is where the bladder resides, as well as urinary tract infections can ensue. When we talk about prevention for BPH, it's described as an enlargement of the prostate occurs as men grow older. So there is nothing to prevent it. There are things that we do to minimize its effects. Really maintaining a healthy lifestyle is what's currently recommended by the American Urologic Association. Testosterone can make BPH symptoms worse, and the reason for that is because testosterone drives the growth of the prostate. By driving the growth of the prostate, it will actually cause a further blockage of the urinary tube. And so yes, testosterone can worsen BPH symptoms. Surgical interventions require most commonly a hospital stay and either a general anesthetic or a spinal anesthetic, so it tends to be a little bit more invasive versus a microwave therapy, which is done in the office. It takes about an hour to do. It is something that the patients go home right afterwards and don't require a general anesthetic for. With BPH, it's described as a blockage of the urinary tube, and so with that we have a couple different risks associated with long-term blockage. One is recurrent urinary tract infections with urine sitting in the bladder. That increases the risk of infections. Number two, bladder failure, because the bladder is unable to empty out the bladder. And then number three would be renal failure, whereby the kidneys fail because their urine is not able to be pushed down into the bladder. BPH is a very common condition that affects the majority of men as they age. It's just a matter of how soon they begin to develop symptoms. Risks of not seeking treatment are threefold. Number one, there's an increased risk of urinary tract infections because the urine is sitting in the bladder for such a long period of time. Number two would be bladder failure because of the fact that the bladder is unable to empty the urine. And number three would be kidney failure because the urine isn't able to come down from the kidneys. So those are the three common side effects that we most worry about. An elevated PSA is a level that's higher than what's considered normal. Now that'll be determined by your doctor, so it's a good idea to talk to your doctor about what the normal limit is. But an elevated PSA is above what's considered normal, and when that occurs, we do get concerned about the potential risk for prostate cancer. There are multiple causes for an elevated PSA. One of them is a benign prostatic hypertrophy, also known as BPH, so that's something that's benign. It can also be due to infections. It can be due to inflammation, and yes, it can also be due to prostate cancer. And so it's up to your doctor to determine which one of those the elevation has come from. So it's a good idea to get the PSA checked out, as well as having a digital rectal exam by your physician. Elevation of a PSA currently cannot be prevented. It's a matter of if it does get elevated, there could be different reasons why it can be elevated, and that needs to be determined by your doctor, because there's ways to bring that PSA down if they're artificially elevated. In conjunction with the PSA test, the second part of the screening for prostate cancer is a rectal exam. That's done by the physician. Most commonly, he uses one finger to feel the size of the prostate, and by doing so, we determine if there's any abnormalities within the prostate, and if there are, those need to be further evaluated. Prostates are only in men, and so therefore women do not have prostates. Men do, and obviously they do need to get them checked for prostate cancer. Enlargement of the prostate can affect your sex life. The reason for that is because enlargement of the prostate can end up pushing on the nerves, which are on either side of the prostate, and therefore, yes, it can affect sexual function, especially erectile dysfunction. Is BPH hereditary? It can be. We tend to see that families who have enlargement of the prostate tends to run through generations. So commonly, if your father had prostate problems, there's a good chance you'll have prostate problems, just a matter of when.
There are typically three treatment options for pelvic organ prolapse. One treatment option is just simply observation. This is a quality of life problem, and patients typically decide when they want treatment. So observation is a reasonable choice. Second option is using a pessary, which is a round silicone object that is placed in the vagina to hopefully hold the pelvic organs in place. This is a very non-invasive approach to helping prolapse. However, the problem with that is it does require changing the pessary every several months, and if you're sexually active, that would present a problem as well. And the last option is surgery.
I'm very frequently asked really about what the natural progression of sexual dysfunction is. First of all, this in one sense is an absolutely elective intervention. A lot of people, a lot of couples are not sexually active and very happy. Some couples are bothered by it, a lot of couples are, and some individuals, whether they're partnered or not, are bothered by the fact that sexual function is not what it used to be. The big question is, what is the red flag that sexual dysfunction is waving at? Is that if I don't have good blood flow to the vessels in the penis, does that mean that I'm going to have a problem with bigger blood vessels to my heart or my brain later on? And the answer is yes. Sexual dysfunction is a red flag. Erectile dysfunction specifically is a red flag for the potential heart attack 5 years from now, stroke 5 years from now. So leaving that unattended is a mistake as far as general health. Whether you treat sexual function or not, that's a personal issue and an issue that you as an individual or you as a member of your partner make a decision on. But it's important to look at it and not overlook it as a general health point of view. Issues of libido, energy, low testosterone, yes, that people will feel better. As we get older, testosterone normally declines, so it's something that we would want to take a look at and improve upon. But more importantly, or as importantly, if we are ignoring the signs of low testosterone, we are again ignoring another red flag. Low testosterone, low muscle mass, weaker bones, and the chance of breaking bones. And after a certain age, the risk of dying from a significant fracture, a hip fracture, could be in upwards of 50% because of comorbidities that occur. So ignoring the signs and symptoms of sexual dysfunction in one hand is a personal choice based on your interest or desire in improving your sex life. But you can't disregard, you can't walk away from the other concerns or the other early signs of more significant physical issues.
The Department of Sexual Health is a unique facility dedicated to evaluating and treating both men and women for sexual dysfunction. We are proud to offer such a facility and reach out to our community in an effort to raise awareness about the potential risks that cause sexual dysfunction. We believe that this private issue is becoming more open to discussion with the men and women of today, and we are here to help rekindle relationships as well as teach wellness, healthy lifestyles, and bring back a quality of life we all deserve. At the Department of Sexual Health, we are here for you when you're ready for us.